Our lecture today is on headache, and certainly of all of the clinical syndromes and conditions we'll talk about in this course, this is the most common. The most common that I see as a neurologist, and in some studies, one of the top reasons for patients to come to an emergency room. So any of you that are going into primary care will certainly see many patients that complain of headaches. And so from the International Classification of Headache Disorders, and we'll kind of be going through it in this manner, we'll divide headaches into primary and secondary headaches, and I'll describe what that means here in just a minute. And then we'll say a little bit about painful cranial neuropathies and some other facial pain syndromes. All right, so first we have secondary headaches, and these are really the headaches you don't want to miss, because the headache is a symptom of something else that's going on, and that something else may be something that's very serious. So you don't want to miss these, and these can be either intracranial or extracranial disease processes. And so kind of the tricky thing when you see a lot of patients with headaches is you're going to see a lot of migraine, tension, and other more benign, not that the pain isn't severe, but they're not life-threatening. And so if you've seen 100 patients with migraine headaches in a row, you're just going to assume the next patient coming in with a bad headache also has migraines. So we always have to kind of refresh with every patient coming in with a new headache and make sure that we're not missing a secondary headache. So very important to perform a detailed, comprehensive neurologic examination in a patient coming in with a headache. So patients with a secondary headache, and I'll list several different causes, but for example, a tumor or a mass lesion, well, they're going to complain of headaches, but they're generally also going to have some focal findings on the neurologic examination and probably some focal complaints as well. So we have to do a careful neuroexam. Also, always do a careful eye exam in patients coming in with headaches. What you're looking for is papilledema. All right, so this will be very important and really need to spend a lot of time practicing this. I think I told you in the first year neuroscience course that for me this was the hardest part of the neurologic examination to really feel comfortable with. So, if you've got a patient in the emergency room at 2 in the morning complaining of bad headaches, and you're going to look in the eye and see if there's papilledema, well, you hopefully have looked in hundreds of eyes prior to that, and you know what normal looks like. So one thing that is very reassuring if you see it are venous pulsations. And this takes a lot of practice, and ophthalmologists are better at this, partly because they do this all day long, but also they can do a dilated eye exam so they get a better look. But what you're looking there is for just you see a little pulsation in the retinal veins. And if you see that, it means that the patient has normal intracranial pressure. All right, so that's always reassuring. So the brain itself is not tender to touch. I've seen patients awake during brain surgery, and you can touch the brain. It's not painful. The pain fibers are in the coverings of the brain, the meninges, and also in the blood vessels. So things that will cause a secondary headache are conditions that irritate the meninges, stretch the meninges, or the blood vessels. All right, so we'll contrast that with primary headaches. And again, migraine, tension type, cluster, these would be our most common primary headaches. So the pain can be horrific, but it's a benign process compared to some of the secondary headache syndromes. All right, so some causes, and again, it's not that we don't see this very often, but a mass lesion like a tumor could present with headaches, but generally there will be other complaints. If the tumor is growing on the right side, there may be some complaints of left-sided clumsiness, or the patient may have a seizure from irritation of the neurons in the brain. Abscess could have a similar presentation as a tumor. It's sort of a expanding mass lesion. In general, this is going to present a bit more rapidly in most patients, and because it's an infection, they may also have a fever. Intracranial hemorrhage. A headache may be a significant complaint of that, but again, depending on where the hemorrhage is in the brain, you would expect to have some focal complaints. Meningeal inflammation, like a meningitis or a subarachnoid hemorrhage. Okay, both of those are going to irritate the meninges. So in a meningitis, wouldn't just be headache, but also severe neck stiffness, like flexing the chin down to the chest would be very uncomfortable. And of course, fever would be part of that. Subarachnoid hemorrhage, we'll say a lot more about this in the stroke lecture, but here we have aneurysm that ruptures and the blood goes into the subarachnoid space. In general, most of these patients do not have focal symptoms because the blood is coating the brain in the subarachnoid space. But the notable exception, there are a few, but the one you need to know for sure is a posterior communicating artery aneurysm that when it ruptures may compress the third nerve. Hydrocephalus, so let's say we have a patient with cerebral aqueduct stenosis. They're going to develop dilation of the third and lateral ventricles, and so they'll have increased pressure, and so they'll have headaches, but also other symptoms of increased intracranial pressure, like confusion, sedation, nausea, vomiting. Those would all be symptoms that might suggest some increased intracranial pressure. And if someone just is sick, like with the flu, or in studies looking at patients with COVID, just a systemic illness, a headache will be a very common complaint along with that. So here's a CT of a patient with a subarachnoid hemorrhage. And so you can see blood here outlining around the midbrain and in the subarachnoid space here extending out into the sylvian fissure. Remember, only two things are allowed to look bright on a CT. Calcium, here's the calcified skull, and an acute hemorrhage, which we see right here. All right, less common, but we certainly don't want to miss these. Some things in the eye, like glaucoma. I tell the story every year, but I had a patient 15 years ago or so that came in with headaches. There were some migrainous features. They were sort of behind the eye, and I treated her for a couple times for things for migraines, and then finally occurred to me that there might be something else going on. Sent her to an ophthalmologist, and she had glaucoma. So occasionally, we can mistake a primary headache for a secondary headache or vice versa. Kids in particular that have ear infections like otitis media, they may not be very good at describing their symptoms. They may come in complaining of a headache. So you want to always do a careful ear exam, make sure there's nothing going on there. Dental pain can occasionally, we can get referred pain from that, and patients may complain of a headache. Sinusitis is something that's quite overdiagnosed. So a lot of people think that they have frequent sinus headaches, but in large studies, this is actually not very common. And so, at least as a cause of recurring headaches. And one reason is people that have migraines often do have some sinus, what we would think of as sinus symptoms. Some pain behind the eye, even some stuffiness. But this would be certainly a treatable cause of headache that we wouldn't want to miss. And in the elderly, because of degenerative changes, especially in the cervical spine, arthritis, this would cause a headache that is generally going to start in the neck, the back of the head, and wrap forward. Now let's go into a couple of secondary headaches in more detail. So idiopathic intracranial hypertension. The older term for this is pseudotumor cerebri, but a lot of neurologists still use that term. And so this is unique because it's a distinct patient population. It tends to be younger, obese women that develop this type of headache. And it's not clear exactly why it occurs more in young, overweight women, but at least there's a couple of theories. There may be impaired venous outflow through the venous sinuses or out through the superior sagittal sinus. And there may be some defective CSF absorption through the arachnoid granulations. We'll talk in just a minute about the transverse sinus and how that may relate to the development of this syndrome. So there are a number of things when you're thinking about this condition. So you've got a young, overweight woman who's having headaches, and you'd always want to do a careful medication inventory. Tetracycline I highlighted here because I think that would be pretty high yield for step 1 boards. So maybe you've got someone taking that for acne or some other reason, and that's associated with the development of this condition. Also, taking too much vitamin A and growth hormone would be a couple of other things that would go along with this. So the complaint is headaches, but because there's increased intracranial pressure, the brain is in an enclosed box, the skull. There are very few places for that pressure to go. But one of the places is out towards the optic nerve head. And so we can have swelling around the optic nerve head, and that is papilledema. And so what patients may complain of with papilledema is an enlarged blind spot. Well, they're probably not going to complain of that, but you might notice it on exam. But more typically, they have what's known as transient visual obscuration or changes. And so they have brief episodes where they may go blind related to a change in head position. So I've heard this story several times, bending over to tie their shoes, and briefly their vision seems to black out. Okay, and that happens because of shifting pressure around the optic nerve head related to movement. Right? So that little bit of a story would be quite concerning to you and would suggest that the patient may have papilledema. All right, so just a couple of images here. There's a really obvious papilledema here on this side. And so when you have that story, you're thinking about this condition, we always need to do a brain scan first. And MRI with an MR venogram is the study of choice because many of these patients will have stenosis of the transverse venous sinus. And so we see this more often than not. And there are some theories about, chicken and egg kind of thing. Does this condition start because of stenosis of the transverse venous sinus, or does this condition lead to stenosis of the transverse venous sinus? And as of now, people aren't entirely sure which is which. But we always have to do the MRI first, not the lumbar puncture. Okay, that's very important because with the lumbar puncture, you can certainly prove that the patient has elevated opening pressure. But this condition, formerly called pseudo-tumor, because it presents sort of like a tumor, sort of like a mass lesion with headaches, increased intracranial pressure. And remember, you do not want to do a lumbar puncture in someone that has increased intracranial pressure. You could precipitate herniation of the brain. So we always have to do the brain scan first. We've ruled out a mass lesion. Maybe we found transverse venous stenosis, and then we do the lumbar puncture to document the elevated opening pressure. And when you remove a lot of cerebral spinal fluid, oftentimes the patient will report that their headache is a lot better. That's not going to last for long, but it's a kind of a temporary thing. So normal opening pressure when you do a lumbar puncture is 15 to 18. This can depend on the units, but at centimeters of water it's 15 to 18. And this is with the patient lying flat and the legs stretched out. So more than 25 is abnormal. Okay, now a lot of lumbar punctures are done with the patient sitting up. And here normal is up to 50. All right, so whenever I hear a report about elevated opening pressure, I always want to know what position was the patient in. And if their knees were crunched up to their abdomen when you check the opening pressure, that's going to cause it to go up. So the legs need to be stretched out when you're measuring the opening pressure. All right, so here's an MR venogram. So this is a pretty normal looking transverse sinus here, but notice that the yellow arrows here on both sides, you've got stenosis here, bilateral transverse venous sinuses. So again, frequently that is seen on our MR venogram. All right, so once we've done our MRI, MRV, and lumbar puncture, if all of that fits, we diagnose idiopathic intracranial hypertension. All right, and so treatment here is usually weight loss, low sodium diet. There really isn't great evidence-based medicine about weight loss, but it's usually recommended. The medication acetazolamide is very effective for the headache of this condition. So basically it decreases the production of cerebral spinal fluid by inhibiting the sodium ions in the choroid plexus. So frequently that's all we need to do. Put the patient on acetazolamide, headache gets a lot better. Now the biggest concern for patients with this condition is visual loss. Okay, if you chronically have increased pressure against the optic nerve head, it is possible to have permanent visual loss with this. And so these patients need to follow very carefully with ophthalmology. They do frequent formal visual field testing because that's the most sensitive way to detect if the patient is developing visual loss. And if that can't be controlled, then an ophthalmologist can do a procedure that is known as an optic nerve fenestration. And as I understand it, they make these little cuts in the optic nerve sheath, and so that when pressure goes forward to the optic nerve head, it kind of gets diffused away. Okay, so we do optic nerve fenestration for prevention of visual loss if that is developing. And if we have a refractory headache that isn't responding to medications, and there would be some other medications that we would try, but acetazolamide would be our first choice, then we can send the patient to a neurosurgeon for shunting, okay, where they put a little tube in the ventricles to relieve the pressure. And so we can see here before and after. Here we have significant papilledema, and notice the much sharper disc margins here after shunting. Or this may be what we see after putting the patient on acetazolamide. All right, and I just mentioned this for interest because this is a fairly recent development just in the last 3 years or so about this stenosis of the transverse venous sinus. So again, is this what initiates the whole thing, or is this a result of the increased intracranial hypertension? It isn't known, but here this was just a couple of years ago that there have been over 538 patients up to that point, so there have been a lot more now, that have had stenting of the transverse venous sinuses. And so you can see that here's 371 patients with papilledema, more than half had it resolved with shunting of the transverse venous sinus. And if we look at opening pressure, blue here is prior to stenting of the transverse venous sinus, and red is after. And you can see that the pressure goes down quite a bit. And so probably this will be the trend going forward more and more, especially for more refractory patients, would be to put a stent in the transverse venous sinus. All right, so that's one important condition. Another is giant cell arteritis. So temporal arteritis, older term, but still frequently used. And this, like pseudotumor cerebri, has a unique patient presentation, and it's generally the elderly. So almost always over 60, and really most of these patients are over 65 and even 70. So this is a vasculitis, so an inflammatory condition that affects blood vessels, and it's mainly the extracranial blood vessels. Intracranial blood vessels can be involved, but usually to a lesser extent. And so any older individual coming down with a new headache, this should always cross your mind. So if you had to just ask one question in someone coming in, 75-year-old man, let's say, coming in with headaches, you would like to know about jaw claudication, because the extracranial blood vessels supply the chewing muscles. And so if those are involved, then chewing food, patients will complain of this crampy pain related to chewing. That's called jaw claudication. And it's seen in about 2/3 of patients with giant cell arteritis, and it's highly specific if you find it. Okay, because this is a vasculitis, there can be some systemic features like polymyalgia rheumatica, kind of a diffuse achy pain throughout, usually with low energy, and there may be a low-grade fever that goes along with that. So the biggest concern, just like with idiopathic intracranial hypertension, is that these patients can have permanent visual loss. And so untreated, you can see that 35% of patients will go completely blind with this. So frequently when we're considering giant cell arteritis, we often bring these patients into the hospital, make the diagnosis while they're an inpatient so that we get things addressed right away. So these patients can have an ischemic optic neuropathy due to this vasculitis. And so really anyone coming in, older individual with sudden visual loss in one eye, have giant cell arteritis in the differential. Okay, we should always exclude that in patients who are coming in with acute visual loss. This is what we're trying to prevent here. All right, some ideas. What goes wrong in giant cell arteritis? Well, there may be an infectious agent, and it isn't known, exactly what that is right now, but it seems to cause immune dysfunction, and especially here affecting macrophages, the interleukin-6 from these activated macrophages. And so what happens is we develop this IL-6 here on the blood vessel wall here of the temporal artery. Okay, so that seems to somehow be involved here in the pathogenesis, and that's supported by a medication that acts on these IL-6, which I'll talk about here in just a minute. So how do we make a diagnosis? Well, first thing, we order a sedimentation rate and a C-reactive protein. Now, these are very sensitive tests, and in a large study, both of these are normal, and only 4% of patients who are later proven to have giant cell arteritis. So general rule of thumb is if your SED rate and C-reactive protein are normal, your patient does not have giant cell arteritis. Okay, so let's just say we have a 75-year-old man coming down with a new headache, maybe some jaw claudication, has an elevated SED rate and C-reactive protein. We still would really like to confirm this by doing a temporal artery biopsy, okay, because you're committing that patient to frequently long-term steroid use, which has a lot of side effects. So you just want to be certain that our diagnosis is correct. So we always request a temporal artery biopsy in these patients. And so once we really think we've got a patient with temporal arteritis, usually they're in the hospital, we're going to start them on steroids. Now, if they're on steroids for too long, it can impair the ability of us to detect this on a temporal artery biopsy, but they need to have been on it for some time for that really to be an issue. So usually we're just going to go ahead and start them on steroids. The headache gets better. That should prevent the development of any visual loss. And then we have a new monoclonal antibody, which does target IL-6. Okay, and so this medication, right now we're using it in conjunction with steroids. I believe there's a larger study out to see how effective this is as monotherapy. But tocilizumab, remember if it ends in MAB, it's a monoclonal antibody, targets that IL-6 receptor. And there's very clear improvement with this medication. It appears to be a pretty big breakthrough in the treatment of giant cell arteritis. All right, another secondary headache to be aware of is spontaneous intracranial hypotension. Okay, and this is not real common, but it has such a unique presentation, and it's just important that you recognize, at least if you hear a story and you're thinking, boy, this sure doesn't fit for migraine or tension type headache, you want to have a differential, what other things could it be? So these are generally women, 4th or 5th decades would be most common onset, and they have a relatively abrupt headache, and it's due to CSF leakage into the dural space. So this can sometimes be related to some trauma, even minor trauma, and there's a little bit of a dural tear, and then the CSF leaks into the dural space. So it's more likely in people that have arthritis, degenerative disc disease, like I mentioned, sometimes after a car accident I've seen this, or other connective tissue diseases where patients would be more prone to having a dural tear. So the unique thing about this syndrome is that the headache is horrible when patients are sitting up and standing, and it goes away when they lie flat. All right, and so if you hear that story, you want to think about this condition. Well, if you hear that story, you'd also want to think about one other condition, and that is, did the patient just have a lumbar puncture? Because that would be very classic. If you do a lumbar puncture and you pull the needle out and you don't get a good seal around where the needle pierced the dura, then that would have the same type of headache. Okay, post-LP headache usually resolves over time, but as we'll see, both of these conditions are treated in the same way. All right, so we've got a postural headache, and so we always do an MRI in these patients, and what you see here, we give contrast with the MRI. Remember, that's called gadolinium. And so the meninges just light up like a Christmas tree in spontaneous intracranial hypotension. So this really suggests the diagnosis. If we do an MRI of the spine, here we can actually see the dural tear right there. All right, so we do an MRI. We can also do a lumbar puncture, and here we're going to find a low CSF pressure, less than 6. All right, so how do we treat? Well, what we can do is it's called an epidural blood patch. Usually this is done by an anesthesiologist, and so you take some of the patient's own blood, and here you inject it, and it has the effect of just sealing off the area of that dural tear. And the blood doesn't need to be injected exactly to the space where you have the dural tear, because the blood diffuses over quite a significant distance. But this is also what we do for a post-lumbar puncture headache. So you've done a lumbar puncture, patient has a horrible headache when they sit up, stand up. It doesn't go away after a few days. These patients also respond very well to an epidural blood patch. Just a little blood into the epidural space here. Okay, and then the last secondary headache we'll talk about here is a colloid cyst. These are usually in the third ventricle, but can sometimes be in the lateral ventricle. And it's just a developmental malformation. Frequently we see this on a CT or an MRI scan, and it's asymptomatic. It's not causing the patient any problems. Okay, but because these tend to be mobile, it's like they just kind of float around, they move around in there a little bit, it can intermittently cause a non-communicating hydrocephalus. And so usually when that happens, it's a real brief spike in increased intracranial pressure, and this can sometimes cause a severe headache with nausea, vomiting, and drop attacks. The patient may even briefly pass out because of the brief spike in intracranial pressure. And there have been some rare cases of sudden death related to that spike in intracranial pressure. So here we can see, here's the third ventricle right here in the lateral ventricles, and there is the colloid cyst. Okay, it just kind of always looks like a marble kind of sitting in that location. And here's one sitting right here in the third ventricle. All right, but remember, here's the cerebral aqueduct, and so, you could have this kind of floating around and can intermittently occlude flow of CSF and cause those headaches and drop attacks. So if these are symptomatic, you'd want to send the patient to neurosurgery, and there would be some options. Here, I think in this case, they would go through the nose and could probably extract the cyst. Okay, now let's go through the primary headache syndromes. Migraine is the one you'll certainly see most often. When I was a medical student, we just learned about vasoconstriction and vasodilation, as if that was really what was going on causing the headaches. But it's felt now that those are really an epiphenomenon of something else, much deeper and more foundational that's going on. So the neurovascular theory is, I think, probably our best way now of explaining migraine headaches. And so according to this, there is initially a wave of what's called cortical spreading depression. And it isn't really known exactly what triggers that, okay, but this is the aura, the warning that the patient will have prior to their headache. And this is what is associated with vasoconstriction of blood vessels. So think of cortical spreading depression as this kind of intense electrical chemical change in the brain that causes depolarization of neurons and glial cells, huge release of neurotransmitters, and we get vasoconstriction. And so during the aura, I'll describe a little bit some of the visual changes and other things that patients may have during the aura. Okay, this cortical spreading depression leads to activation of the trigeminal nerve system. Okay, and so this actually kind of in correlation with this actually affects the blood-brain barrier. We get a leaky blood-brain barrier as a result of the cortical spreading depression. So the trigeminal nerve releases substance P. That's a neurotransmitter you'd want to associate with pain. But even more important than that is CGRP. Okay, this is the neurotransmitter that is most important as it relates to migraine headaches. And so the trigeminal vascular connections here cause dysfunction in the dura, contributes to the leaky blood-brain barrier, and so we get what's called neurogenic inflammation, and now this is the vasodilation that occurs. But again, that's an epiphenomenon of everything else related to cortical spreading depression, activation of trigeminal nerve afferents. And so, but during the vasodilation phase is when the patient complains of a severe headache. So interestingly, we'll go over the medications here, but sumatriptan is one we mentioned last year. And so we often tend to emphasize the effect that sumatriptan has on blood vessels, but perhaps more importantly, when you give sumatriptan, CGRP levels drop down. And that may be why it's very effective for aborting a migraine headache. All right, so we have CGRP receptors here. We can see along the meningeal arteries, in the trigeminal system here with the trigeminal ganglion, and this is the spinal trigeminal nucleus here going through the brainstem. Remember we said last year that this is the continuation of the substantia gelatinosa, which is for pain in the spinal cord. Okay, so we have the CGRP receptors here as well. All right, so remember that the dura is supplied by the V1, V2, and V3. And really here we mainly see the falx cerebri and the cerebellar tentorium, which are both supplied by V1 of the trigeminal system. V2 and 3 supply the anterior and middle fossa. Okay, but when we have an abnormal activation of the trigeminal system, it's going to affect the falx, the cerebellar tentorium, and the other dura here. Remember, that's where your pain fibers are located at. So to get migraine headaches, it's multifactorial. So at least half of patients have a strong family history. So you always want to ask if there are family members with migraines. But there are environmental factors, a previous serious head trauma and some other exposures may all come together and make it likely that someone has migraine headaches. So you can see migraines, a lot of people never see a doctor with migraines, but somewhere between 4 to 15% of the population have had at least one migraine. A little more common in women, and the peak age is between 30 and 39, but you'll see a lot of children that have migraine headaches, and I see some elderly individuals that have migraine headaches as well. All right, so what are the clinical features of migraine? First of all, they're incapacitating if untreated. And so that's what I'm really listening for. One thing I'm listening for very carefully, if a patient can function during a migraine, they can go to class, they can work. That wouldn't be typical. It's really hard to function during a migraine headache. So these are quite severe recurring headaches. The pain is most often described as having a throbbing quality, but it can be variously described as a very intense, dull ache, pressure, stabbing, but throbbing would be most common. For most patients, the migraines tend to be more often on one side than the other. Okay, not always. Nausea and vomiting is quite common with migraine headaches, and photophobia and phonophobia are almost universal. So patients during a migraine headache are very light sensitive. They prefer to lie down in a dark room, and they're usually sound sensitive as well. So a lot of patients I've seen, women with migraines, they're trying to take care of their kids or whatever, just the noise and everything, just really want to get into a quiet, dark room. That's what patients with migraine prefer to do. So the duration on average is between 6 and 24 hours if untreated. Now, about a quarter of patients will have an aura, And this can take a variety of different features, from a mood change or just feeling drowsy, maybe irritable. And so patients have learned that, this may be, warning me that I'm going to have a migraine. We use the term a classic migraine to describe patients that have very distinct visual symptoms prior to the development of a headache. And generally this is going to last for 10-15 minutes, and then the patient will have their headache. And so there are just a variety of different, quite dramatic visual distortions that patients can have, kind of a donut or a donut hole effect, a loss of vision, sometimes a central scotoma right here. This is called a fortification spectra, like these Middle Ages, the walls here on the castle. Sometimes these can be quite colorful, bright lights, and so patients are aware of that, and once you've had this a few times, you know that a migraine is coming. And sometimes, what happens in the brain during this aura phase of cortical spreading depression is quite intense. And so if we involve the motor cortex, patients may have a hemiplegia. If you involve the language areas, patients may have an aphasia. I've seen a number of patients that have a homonymous hemianopsia. All right, so if you've got a young, healthy individual that keeps having these episodes of aphasia or visual loss, well, that's not likely to be a stroke, unless they have lots of risk factors for having stroke. So you'd really want to consider migraine headache here as the most likely thing. And if you want to just, when the lecture is done, you can Google reporter and aphasia, or in YouTube, and you'll see a reporter here that during a broadcast had a migraine and developed an aphasia and related to that. Now, migraine equivalent describes patients that have this aura, but it isn't followed by a headache. So sometimes it's called a silent migraine headache. I had this once in my life after we went someplace for a healthy shake, and about 10 minutes later I had these bright sparkling lights off to one side, I lost my vision off to one side, and I never had a headache later, but it clearly was a migraine equivalent. All right, so just be aware this is not uncommon. Hear that description. Now, as it relates to women, oral contraceptives in patients that have migraine with aura, so the classic migraine, are at 2 times increased risk of developing a stroke, and if those women also smoke, they have a 10 times increased risk of stroke. And so that is really kind of the perfect storm here. So just be aware of that in women with migraines. So in general, in women with migraines with aura, we want to use low estrogen or some other form of oral contraceptive or progestin only. I'll just say one comment on this. A lot of the data on this 2 times increased risk, relates to older oral contraceptives which had a much higher estrogen concentration. So this may be overestimating here a little bit, but clearly if you've got a woman with aura who's smoking, she should not be on oral contraceptives for sure. All right, there are lots of triggers for migraine headache. Stress is certainly the most common. Women will frequently have migraines related to hormonal changes. Some individuals are quite sensitive. If they go too long without eating or drinking, they'll get a migraine. I've had a lot of patients just with seasonal changes will have a headache. Poor sleep is another very common one. I've had a lot of patients that certain perfumes. One lady told me years ago that if she walks into the house and they have perfumed toilet paper, she will get a migraine headache. So you can see there are quite a few others here. I always ask patients if they've noticed if they eat something like something with MSG or maybe chocolate. A number of different foods can sometimes be associated with migraines. But if your patient has had enough migraines, they've usually figured out what their triggers are. All right, so how do you treat migraine? Well, first, abortive treatment. Some patients do just great with aspirin, acetaminophen, which is Tylenol, or non-steroidal anti-inflammatories like ibuprofen, naproxen, a lot of medications in that family work very well. I don't see these kinds of patients because in neurology we're only going to see the more refractory headache patients. But some patients do great with over-the-counter medications. You'll notice, and I would encourage you sometime, just go to the pharmacy and look through some of the medications that are there just to kind of get an idea. But you will see a lot of migraine medications have caffeine in them. And caffeine is actually helpful for abortive treatment of migraine. As we'll see, the problem is if you use it too often, then it actually tends to promote the development of the headache. So Excedrin is probably the one that's used most often as a medication that has caffeine in it. All right, so let's say we have a patient who's not responding to acetaminophen, NSAIDs, we're looking for something else. Serotonin agonists here, or the triptans, are a highly effective class of medications for aborting migraine headache. And there are 8, maybe even 9 medications in this family, and I would really just like you to know one, and that is sumatriptan. Sumatriptan is available as a pill, it's available as a nasal spray, which kicks in a little faster, and it's even available as an injectable form. We use that most often for patients maybe that wake up in the middle of the night with a migraine and are vomiting, because then it's too late to take something oral. So injectable form kicks in quickly in that setting. So sumatriptan, we mentioned last year, is a serotonin 5-HT1B and 1D receptor agonist. And so remember that our CGRP levels decrease when you give sumatriptan and you see some vasoconstriction. Okay? Because remember, the headache is associated with the vasodilation phase. Very important, we cannot give sumatriptan in patients with coronary artery disease, uncontrolled hypertension, if they've had previous strokes, or if they have peripheral vascular disease. So the vasoconstriction properties of this medication mean we don't want to give it in this setting. Just within the last year, there is a triptan that came out that does not cause vasoconstriction, but it's so new I'm not going to ask you about it. But it's an alternative for patients that we can't give sumatriptan. Now, if you're in the emergency room, because triptans need to be given soon, right? So if you're seeing a patient hours into a migraine, it's usually too late to give a triptan. So here we often give IV dopamine blocking medications, metoclopramide or prochlorperazine. Remember, we mentioned both of these as medications that, if taken frequently, can cause Parkinsonisms and all kinds of bad side effects. But as a one-time IV dose in the emergency room, no problem. And these actually work quite well, not just for nausea and vomiting with the migraine, but it actually is helpful to abort the migraine headache. In general, we do not want to use narcotics or opioid-type medications for migraines, because the more often someone takes these medications, it promotes developing more migraine headaches. And we don't like to use butalbital-containing medications. Furanol would be probably the most common one that's used here. Butalbital, it's usually a combination medication of butalbital, maybe with aspirin or a non-steroidal and caffeine. It's all together in that one medication, like Furanol. And again, the problem is you get rebound headaches with these. So the more you take of this type of medication, the more likely you are to get more headaches. All right, so if we have someone with frequent headaches, and in general, 3 or more migraines a month is a lot to have. And so we'll usually use prevention, kind of use common sense. You know, I have a patient that has 1 migraine a month, but it lasts for a week. So we're going to use prevention, you know, in that setting. So how much is it interfering with the quality of life? So there are kind of our 3 major categories of medications, oral medications for migraine prevention. First, we have the tricyclic antidepressants. These work really well. Most books, most board review books will list amitriptyline, but any neurologist I've ever worked with always uses nortriptyline, okay? And nortriptyline, we prefer nortriptyline because it has fewer anticholinergic side effects as compared to amitriptyline. So remember these medications here, where they'd act on the parasympathetic system, cause some sedation, dry mouth, constipation, urinary retention. These would all be side effects of a tricyclic antidepressant. So they work well, but especially if in the elderly, like over 65, you'd want to be very careful because these are patients prone to confusion, constipation, urinary retention. Okay, so they're effective, but have some side effects. Next we have the beta blockers. And so propranolol is the one that's used most often. And now there's some theories, and this may seem like it's conflicting here. In the brain, it's felt that it has something to do with the firing rate in the locus ceruleus, and so it alters perhaps release of norepinephrine. Now remember, the tricyclic antidepressants here block the reuptake of serotonin and norepinephrine. So it just appears that somehow altering norepinephrine in the brain has something to do positive with prevention of migraine headaches. This is just a theory about perhaps why beta blockers may be helpful. So if you're considering using a beta blocker like propranolol for migraine prevention, we don't want to give it in a patient who has asthma. Okay, so that would be contraindicated, especially if they have a more severe case of asthma. And beta blockers can increase a little bit depression. It wouldn't be contraindicated, but it probably wouldn't be my first choice in someone who's being treated for depression. All right, our next category are two anticonvulsants. Topiramate is the one that's used most often, and also valproic acid. I would say of all of these right now, all the medications on the screen, topiramate is probably the one that's used most often. It's quite effective. The mechanism of action of these two medications we will talk about in the seizure lecture on medications. So I won't tell you how they work or their side effects right now because we'll come to that in the seizure lecture. But remember topiramate as a really effective medication for migraine. Now let's just say we've been through those three classes of medications. Then what we would consider next, if we're just not getting an adequate response, are botulinum toxin injections. And these are very effective, even in patients who haven't responded to other therapies. It's quite a few injection sites. You're doing this all the way around the forehead, the temporals, the back of the head. That's almost 30 injections in total. Okay, how does Botox work? Well, you may be thinking, remembering here that botulism and Botox impairs the release of acetylcholine, so we don't stimulate nicotinic receptors on muscle, and so it does have an effect to relax muscles, but that's not how it works for migraines. It turns out, here we have CGRP and substance P, and it turns out that these neurotransmitters are released here at neurovascular junctions, so trigeminal nerve vascular connections, by the same mechanism, the snare proteins. And so it appears that how Botox works, or I should really say botulinum toxin, how it works, is through prevention of release of CGRP, and therefore you get less abnormal activation here of the trigeminal vascular system. Okay, so it's not muscle relaxation, that's not how it works. It's through neurovascular, blocking neurovascular connections, not neuromuscular connections. So botulinum toxin injections last for 3 months, and then the effects here on the snare proteins wear off, and so patients need to keep coming in every 3 months for injections. Now, very recently, within the last couple of years, a whole new group of medications have come out against CGRP, and these are largely monoclonal antibodies. You can see all the ones that have come out, and I would just like you to know one. And we're using this a lot, so it's probably not going to show up on boards for a while, but I would like you to know it, and that is erenumab. And this is, you can see again in the name, monoclonal antibody. It's a monoclonal antibody against the CGRP receptor right here. Okay, so it has a kind of a similar mechanism of the botulinum toxin injections, except we're not blocking release of CGRP, we're blocking the receptor, so it can't be abnormally activated by these trigeminal vascular connections. You can see they're developing, or they have out now, antibodies that are against the molecule itself. And then there are some medications here that are actually antagonists of the receptor. They're not monoclonal antibodies. Okay, but no arenomab. So it's a pretty significant development, and I tell new patients that have migraine headaches who are often quite discouraged that realistically we should be able to find something that will work well for you, and we usually do. All right, next, there is a whole category of headaches that are under the big term of a trigeminal autonomic cephalgia. And I would just like you to know one, and that is cluster headache. Now remember, migraine, and we'll see tension headaches are more common, somewhat more common in women. Cluster headaches almost only occur in men, or at least by like a 9-to-1 margin. And so probably the onset of a cluster headache is actually in the hypothalamus. Okay, and I'll show you a picture here to illustrate that in just a minute. So you can see 85% of patients with cluster headaches are smokers. The pain is usually right behind the eye, and I've even had patients use this textbook term. It's like a hot poker that is just being jabbed right in the eye. Okay. Unlike a migraine, the duration of each headache is shorter, so it may only be like 30 minutes, but not 6 hours or 24 hours. And so because the onset is in the hypothalamus, and remember this is the head ganglion for the autonomic nervous system, we'll talk about circadian rhythms and the hypothalamus in a lecture on sleep. But because of that, patients that have cluster headaches often will tell you that the headache begins at a very specific time every day. Okay, I've even had patients say they can almost set their watch by 3:20 every afternoon or whatever. So it can have a rather predictable time of onset, and the headaches cluster. And by that I mean seasonally. They may cluster during the fall or during the spring. So the patient will have a whole bunch of them, and then they'll just go away until the next fall or the next spring. Now, patients with cluster headache really do not have photophobia or phonophobia. And so unlike a migraine patient that needs to go into a dark room, be very still, patients with cluster headaches usually pace the floor. They walk around holding their eye. Light doesn't bother them at all. Okay, so quite different than the migraine headache. All right, so there's a lot of activation of the autonomic nervous system to the eye or behind the eye, and so usually the eye gets a little red. They may even have a Horner syndrome, and the eye tears, so there's some rhinorrhea, and usually the nostril on the side affected is alternately stuffy and then draining during the headache. So these are all autonomic symptoms here in and around the eye. All right, so here we have the hypothalamus, and so in a cluster headache we get abnormal activation down here of the spinal trigeminal nucleus. And remember, this is very important for pain. Okay, but also we can see here that here's the superior salivatory nucleus. All right, so we get abnormal activation of the parasympathetics. That'll make your eye red and drain, and we'll also we get some nasal stuffiness along with that. All right, so how do you treat a cluster headache? Well, high-flow oxygen works very well. So the patient can put on a high-flow oxygen mask or a nasal cannula. It helps to abort the headache. The problem is, practically, these patients, they don't get into the emergency room, and the headache's gone by then. And so this is something that you can try to order for home use. It's not always that easy to get a canister of oxygen in a patient, if it's not due to some pulmonary disease, but that works well. Sumatriptan as a subcutaneous injection, just like it works for migraine, it's helpful for cluster headache. But really, these are just horrible headaches, and so you want to prevent these from coming on at all. So when a patient is telling you that they're having their cluster of headaches again, generally we're going to start them on 2 medications. Prednisone, which is a steroid medication, we usually give them like a 10-day course. And this is pretty effective at preventing the headaches from coming on. But remember all the side effects of prednisone that we discussed. And so you don't want to leave patients on this. So you give them like a 10-day course, and at the same time you start them on verapamil, which is a calcium channel blocker. Verapamil really does not work for migraine. It works very well for cluster headache. It's considered the drug of choice for cluster headache. So by the time the prednisone, the 10 days are over, now the verapamil is up to a good level in the body, and they stay on verapamil until they're headache-free for a while, then they can stop it. And then, I tell patients, let me know as soon as the cluster headaches come back, and then I get them back on verapamil again with a short course of prednisone. All right, so there are some other things we can do, but I think just what is on this slide would be what I'd expect of you to know for cluster headache treatment. And now, tension headache, I won't say a lot about, but probably most of us have had a few tension headaches in our life. So very common, like migraines, a little more common in women. And most patients that have migraines also have tension type headaches. So there's a lot of overlap between migraine and tension headaches. So this may or may not be true, but at least for boards, they will usually ask you to identify a muscle tension or contraction component to the pathophysiology of tension headaches. Unlike migraine headache, patients aren't as incapacitated. They can function. And there may be a little bit of light sensitivity, but not the extreme light and sound sensitivity like you would see with a migraine headache. And so medications like nonsteroidals, anti-inflammatories like ibuprofen, Aleve, those type medications work well for a tension type headache. So why does someone get tension type headaches? Well, they are more likely, just like with migraines, during stress or fatigue, and frequently we see these due to medication overuse. So if someone is using too much sumatriptan, well, they're going to be more likely to get frequent regular headaches. If someone drinks caffeine every day or is using Excedrin migraine too often, then they're much more likely to get tension type headaches. Narcotic or opioid pain medications. Again, if those are used frequently, patients often get a tension type headache related to that. So there are various terms for this. We can call this a medication overuse headache or sometimes rebound headaches. And oftentimes patients will describe it, just that way. They take their narcotic medication, maybe for back pain, and their headache goes away when they take that as well. But then after a few hours, it comes back really bad, and then they need to take the narcotic medication again. So always do a careful medication inventory in someone that has headaches or frequent headaches. And very frequent tension type headaches, if they're present more than half the time, we use the term a chronic daily headache. And again, frequently related to medication overuse. Same things. Narcotics, triptans, caffeine. Remember the butalbital medications I mentioned, like Fiorinol, that we want to avoid. If you use too much of that, they're highly associated with chronic daily headaches. And I just want to include this a little bit here because it's just so practical and relevant, given that headaches are so common. So the American Academy of Neurology issued this press release to all physicians in 2014 because this is, just really an epidemic, that opioid and butalbital treatment for migraine and chronic headaches should be avoided because more effective migraine-specific treatments are available. Frequent use of opioid and butalbital treatment can worsen headaches. Opioids should be reserved for those with medical conditions that don't allow other migraine-specific treatments. So as a doctor, really, you want to not use opioids or butalbital type medications or caffeine type medications to your patients with headaches. We have better options. So patients who do use opioids or narcotics on a regular basis can develop what is known as an opioid-enhanced hyperalgesia. And there are a number of theories about why this develops, but there are just numerous, just a lot of literature out there describing, here's one looking at 32,000 adults who were on frequent opioid medications that years later were much more likely to develop chronic headaches, chronic migraines, chronic neck pain, chronic back pain. So in other words, the patient maybe was treated for knee pain or low back pain, but then they developed these chronic headaches, and it's related to the opioid medications. So try to find better options for patients than these medications. So if you are going to use an opioid medication, the general rule of thumb is no more than 7 or 8 days per month should it be used. If your patient is taking it more than 7 or 8 days per month, their risk of getting chronic headaches or some other chronic pain syndrome goes up quite a bit. Same thing would apply to caffeine use. Okay, if you have a patient with frequent headaches, well, caffeine use or taking medications with caffeine like Excedrin, no more than 7 or 8 days per month. Otherwise, the headaches are going to be more frequent. All right, another headache that is just very unique, different than anything we've talked about, is sometimes called an indomethacin responsive headache, or sometimes ice pick headaches are also used. And these are unique compared to all the other types of headaches we've talked about in this lecture because the pain lasts for seconds. So it's very intense, but it's very brief. And frequently patients will have autonomic symptoms as well, like a cluster headache patient. So there may be some eye redness or drainage during the headache. These can come on spontaneously or frequently will be related to sexual activity. So this is what's sometimes called a post-orgasmic headache. Right after orgasm, there's an intense headache that lasts for seconds and then it goes away. Or sometimes exertional headaches can fit in this category, like lifting weights or even straining to have a bowel movement can bring on this type of a headache. And so, if you're seeing someone in the emergency room who's had an exploding headache after orgasm, well, there you'd want to rule out a ruptured aneurysm. But if someone tells you, I've had this 10 times after orgasm, an aneurysm ruptures once in your life, right? So a recurring story of severe headaches related to exertion or sexual activity suggests that it's an indomethacin responsive headache. And so the name of the headache syndrome is even after the medication. So indomethacin, which is a non-steroidal anti-inflammatory, but through a different mechanism of action, this works very well for prevention of this headache. So it can be taken just prior to sexual activity, and very high chance it will prevent the headache from coming on. Now, trigeminal neuralgia is a distinct facial pain syndrome. It's usually in the V2 distribution, and the pain here is just horrible. Usually it has an electrical quality. It's very brief and intense, but it's right in the jaw area. And so what happens in trigeminal neuralgia is we think in most cases there's an aberrant blood vessel that is kind of sitting next to the trigeminal nerve fibers just as they enter the pons. And so that irritates the trigeminal nerve and triggers the episode of pain. So the other possible etiology is multiple sclerosis, because as soon as those trigeminal nerve fibers enter the pons, they go from being myelinated by Schwann cells peripherally to oligodendrocytes centrally. And so if you have some demyelination in the pons, then that will irritate those trigeminal nerve fibers and cause the same type of facial pain. So the pain of trigeminal neuralgia is always triggered by jaw movement. And so patients will tell you just trying to eat something, talking, brushing teeth, sometimes shaving, or just touching the face will trigger pain. And I've had a lot of patients that have lost a lot of weight because they're so afraid to eat because it brings on such a horrible attack of pain. Now, when you have pain that lasts for seconds, there's nothing to knock that out, right? Because it's gone. So our treatment here is in the area of prevention. And so here we have two other anticonvulsant or anti-seizure medications, just like when we talked about with migraine. But the two that work here are carbamazepine, that's the drug of choice, and also gabapentin. So again, we're going to go over the mechanism of these medications in our seizure lecture. So for now, just kind of fix the name in your mind. Carbamazepine is a drug of choice, works very well for preventing these attacks of pain. Likewise, so does gabapentin. And there are lots of other options, but if you know those two medications for now, I'm happy. So here we have an MRI, and what you're looking at here, the white here is the CSF. And so the long arrow here points to the nerve. So there's the trigeminal nerve coming into the pons. And over here we have a blood vessel. Okay, and so they're kind of sitting close to each other there. Here would be a very healthy looking trigeminal nerve right here. But notice here we have some atrophy right here, how much smaller it is. So here we have chronic compression of the trigeminal nerve with some atrophy. And here we can actually see the blood vessel right here kind of abutting next to the trigeminal nerve. So this is a patient who has trigeminal neuralgia on this side. And so if we see this and our medications are not really controlling the pain quite well, then we can refer patients to a neurosurgeon, and there are a number of neurosurgical options for this condition. All right, so last slide here. If you're seeing someone with a headache, I just want to kind of go back to just remind you, you always have to do a detailed neuroexam and an ophthalmoscopic exam. So for all of the OSCE, MACI exams that you'll have to take in the 3rd and 4th year, headache would be one of the most common scenarios that you'll be asked, and you will lose points if you don't do an ophthalmoscopic exam. All right, so always have to do that in a patient with headaches. So SNOOP here is a kind of a mnemonic to remind you of red flag warning signs and symptoms. So if a patient has systemic symptoms like fever, myalgia, or weight loss, well, something's going on there. I mean, if it's a meningitis or polymyalgia rheumatica as part of giant cell arteritis, this is not a benign headache syndrome. Or if we have neurological focal signs and symptoms, patients having headaches and they're also getting weaker on one side of their body. That's very concerning, right? We've got a mass lesion. If the onset is sudden, then that would make us think of a subarachnoid hemorrhage. Or if we have onset after trauma, well, it could be a subdural or an epidural hematoma after trauma. Remember, an older individual, we'd always want to rule out giant cell arteritis and a prior headache history. If someone tells you that they've had these headaches for 30 years, well, that's almost certainly going to be a benign etiology, right? But if a patient tells you, I've never had headaches in my life until the last month, well, I mean, that could be just migraines that are starting, but it would also kind of, raise some red flags of lots of other secondary headache syndromes that could be a cause. All right, so we will have some opportunity here to go over case studies in headache, and I'll just make a couple of points on diagnosis here. If in a subarachnoid hemorrhage, we need to do a CT to look for the bleeding and then a lumbar puncture if the CT is normal. We're going to do an MRI scan in most headaches that are not just suggestive of a primary syndrome. So any kind of a secondary headache, we'll usually do an MRI. For giant cell arteritis, remember we do a SED rate and a C-reactive protein, then a temporal artery biopsy. We'll do a lumbar puncture for meningitis, for idiopathic intracranial hypertension, or for the spontaneous intracranial hypotension. So they're either high or low pressure would be diagnosed by lumbar puncture. Remember, do an MRI first. Okay, we don't want to cause herniation of the brain due to a mass lesion. And we can also do a sinus series if we really think that our patient might have a sinusitis. All right, we'll stop there.